My name is Giavina-Bianchi. I am a dermatologist here in Sao Paolo, Brazil. I want to thank the organizers for this invitation. It's a pleasure and an honor for me to participate in this Congress. I'm going to talk about teledermatology and general medicine, our experience here in Brazil. I have no conflicts of interest for this talk. And I want to give you a little bit of context about our experience here in Brazil. Brazil is this country here in South America, and this is the Sao Paulo state. And we have a Sao Paulo city, which is the capital of the state. So in terms of numbers, Brazil has 212 million people, inhabitants. Sao Paulo state has 46 million inhabitants. And Sao Paulo city, which is around 100 kilometers from the shore, it has 12 million people. Sao Paulo state is the richest state in the country. To have an idea, our gross domestic product here in Sao Paulo state is 32% of the whole Brazilian GDP, and it equals to the GDP of 4 of our neighboring countries, Argentina, Uruguay, Paraguay, and Bolivia summed together. Sao Paulo city is the largest and the richest city in the country, and 2/3 of our population here in Brazil depend on the public health system. We have a private health system, we have a public health system, and 2/3 of the population depend on the public health system. Our public health system is called SUS. It's Unified Health System. It was created in 1982, and it's completely free of cost, no co-pays, nothing. And this includes foreign people living in Brazil or traveling to Brazil. Here, I want to give you a little context about our hospital. I'm from Hospital Israelita Albert Einstein. It's a non-profit, but it's a private hospital here. It's a large private hospital. And this hospital, our hospital, was elected 10 times ranked as the best hospital in Latin America. And among 2,000 hospitals in 25 countries by this Newsweek magazine, it was ranked as number 36. So a little bit of our project here in Sao Paulo. This is the flow of the data and the photographs that were collected by us. I want to give you a little bit of context again, because in 2017, there was a new mayor here in the city of Sao Paulo, and he decided that there was too many people in the waiting list for specialties, for image exams like CT, ultrasound, all kinds of exams and specialties. So for dermatology, there was one of the worst with the longer waiting list. So around 58,000 patients were in the waiting list for an appointment with a dermatologist. So this mayor and his team came to our hospital because our hospital had has an expertise in telemedicine since 2012. And they wanted something to speed up this waiting list, to reduce the waiting time. So our hospital proposed to do this teledermatology project. And so the patient in the waiting list, he or she received a phone call, and he was or she was directed to the 3 municipal hospitals participating in this project. And there, a nurse or a health technician, you'd use an app that our hospital created to input photograph of the lesions and some data about the patient and the lesions. And this was uploaded in the app. So the photograph the protocol was usually 3 photographs, one 50 centimeters away to have an idea of the region and the size of the lesion, one 10 to 15 centimeters away to have a close-up of the lesion, and one a lateral view of the lesion to see if it had any volume. About the data collect was the age, sex, time of onset, pruritus, yes or no, bleeding, yes or no, and a brief history of that lesion. All this information was uploaded in the app, and 13 teledermatologists had access to the online platform. And then the first thing the teledermatologists had to do was decide if that photos were good enough to make a report or were bad photos. If they were bad photos, then this patient would be sent to in-person dermatologists. If there were good photos, then the teledermatologist had to provide one of 3 possible referrals. The dermatologist could send the patient directly to biopsy, and then the patient would go to the dermatologist with the result of the biopsies, or the dermatologist could send to the patients to the in-person dermatologist directly, or to the primary care physician kept with his or her primary care physician, and then he would do this report. He would do the report with the ICD-10 code, first and second clinical hypothesis, and then the treatment and some comments about the diagnosis or the treatment. So some of the results that we had here. So patients, 4% of the patients were sent directly to biopsy, 43% were sent to in-person dermatologists, and 53% were kept with their primary care physician. Here about the waiting time, before the project, the patient would have to wait 6.7 months to an appointment with an in-person dermatologist. And after the project, this time was reduced to 1.5 months, which was 78% of reduction. Also, we looked for the most common conditions, the 10 most common conditions, according to sex and referrals, to see if we had any difference. To have an idea of those 58,000 patients waiting in the list, 31,000 participated in the project, and they presented 55,000 lesions. Most of them, 68% were female and 32% were male. According to sex, we saw different complaints for female and for male patients. Female patients presented significant more melanocytic nevus, seborrheic keratosis, melasma, onychomycosis, acrocordon, or other benign neoplasias, and solar lentigo. As for male, we had more acne, atopic dermatitis, and epidermoid cysts. As you can see here, in red, we have the female group, and in blue, the male group, and we see the different results according to the most common diseases. Here, to have an idea about the referrals, the blue one are biopsy, the red dermatologist, and the green kept to the physician. So you can see that most of the diseases, the 10 most common diseases, they were kept mostly with the primary care physician. The only exception is the epidermoid cyst, which is a surgical pathology. So they were sent to dermatologists most frequently. And here you can see that melanocytic nevus had a bit of biopsy directly. According to age and the 10 most common conditions in skin, we can see that in blue we have the children group, 0 to 12, and then the orange group, adolescents and young adults, in the gray group, adults, and in the yellow, older people. As you can see, there are a lot of different combinations here. We can see that melasma, it's almost exclusively in adult patients. We can see that acne has a great deal of patients, adolescents, and young adults, as we could expect. And we see that seborrheic keratosis, for example, it's much more common in older persons. We also looked for the most common diseases among the referrals. So basal cell carcinoma was the most common disease to be sent to biopsy. Then melanocytic nevus, seborrheic keratosis, squamous cells, melanoma, those, of course, malignant lesions had to go to biopsy, but we can see that some funny looking or weird looking benign lesions also were sent to biopsy directly. As for dermatologists, we can see that melanocytic nevus was the most common disease sent to dermatologists. Here we have to make a comment, because if we had the dermoscopy image, probably this would be much lower, because sometimes we don't felt confident enough to send to keep the nevi with their physicians without looking at the dermoscopy. Warts, of course, are treated by dermatologists, and some moderate to severe cases of acne, atopic dermatitis, actinic keratosis is also another disease treated by us. So that was the distribution for the dermatologist group. Back to physician, you can see most of the 10 common lesions really were kept to physicians: melanocytic nevus, acne, seborrheic keratosis, onychomycosis, and so far. So on. Among the treatment, we had 64% of the patients were treated with something, 36% were not treated by the teledermatologist. Those probably sent to biopsy or to in-person dermatologists. Sometimes we don't need it to suggest anything, because we know that the dermatologist would do. And about the drugs used, emollients were the most common medication used. Then topical corticosteroids tied with topical antifungals, 20% each. Sunblock was also very commonly prescribed, and topical anti-acne. Well, we have to talk about limitations. Of course, the fact that the teledermatologist has received multiple photographs with parts of the body and the face and the head, and not it's in his or she is not she's not able to do the whole exam, makes the diagnosis more challenging for us. There is also a fear of missing lesions such as skin cancer. In our case, we were more calm about this problem, because we had to deal directly with the physician and not directly to the patient. So we expect that physicians would follow up the lesions and would request new evaluations if necessary. And some important impressions, such feeling the texture, skin, the size, and the palpation and everything, of course, could not be done. Other limitations that we had, we did not evaluate anything, any characteristic about racial or ethnicity or socioeconomic factors in our population. This would provide valuable information. Also, the project manager had to face a variety of technical issues, delay in the process of uploading images, reports, problems with internet connection, missing data or photographs that led the patients to be recalled. Also, us as teledermatologists, we found problems such as blurry pictures, wrong framing, and the fact that we didn't have the dermoscopy to analyze together with the clinical images, especially in the tumor new lesions, would be good to have it. In conclusion, I think that the teledermatology could really be effective to reduce referrals of most common skin conditions to dermatologists. Also, TD would provide numerous benefits, optimizing in-person visits for patients with serious, complex, or surgical skin conditions. And on the other side, quickly and conveniently address most common disease together with the primary care physician. We could save resources, of course, working days of the patients, patient transportation. And we also think that this project, assessing the most common skin conditions and treatments in primary care, could enable the public system to make some public policies and also train the general physicians on these lesions. So the cost and the flow of the patients would be much better. All our results are here in this article that we published. We also used all this data, photos and data, to play a little bit with artificial intelligence, making it to triage this common scare disease to see how it was. We also looked for specific populations like geriatric populations and pediatric populations and atopic dermatitis, because this was a very common disease among our patients. And also the accuracy for teledermatology in inflammatory and inflammatory disorders and skin neoplasm. This one about the perception of the dermatologist. This was the first one published, and it was something that I felt, and I would like to talk a little bit about it. Because when I was asked to participate in this project, I had never been in touch with teledermatology, really. So I was very skeptical that this could do some good for the patient and for the public system or whatever. And I found after this year of project that I really became an advocate of the teledermatology. In the first 1 or 2 months, I really fought with my computer screen because I wanted a different angle of the lesion or more information about the lesion or the patient. But then I began to realize the purpose of teledermatology. So for this project, so I started to love it. So we published this about the opinion of those 12, 13 teledermatologists, and then we found some interesting results. For future directions, well, that mayor that I told you guys here in the city of Sao Paulo became the governor of the state of Sao Paulo 2 years after. And then he decided to expand the project to the entire state of Sao Paulo. The expectation was to assist 90,000 patients per year during 3 years. And in the second semester of 2019, when this project began, we had about 10,000 patients assisted by Story for the TD. But in the beginning of 2020, as everyone knows, the COVID pandemic affected all the public health system and the private health system also. And they had to move all the financial resources to the combat of COVID-19. So our project was suspended, and as we're still going on this pandemic, we still don't know what's gonna be for the future. Well, that was my talk. Thank you very much for the invitation. If anyone wants to contact me, please feel free to do so. This is my email. And again, it was a pleasure to present this talk in this Congress. Thank you very much.